Today I'll share a rundown of a recent evaluation I did for a patient complaining of knee pain. And I've subdivided it here into the three main parts of my orthopedic evaluation to give you a clear idea of how the evaluation proceeded and what my thought process was. I've only seen this patient once, so more testing will be necessary as usual. But I'm pretty sure I know what the diagnosis and the specific treatment will be because it's a pattern I see a lot with patients. So it's a young male who presented with new onset of knee pain for 3 to 4 weeks. It's been there since a day of playing soccer with his kid, so not a full game, but lots of kicking. And there was not a moment of injury, so no moment where a specific kick popped something or created the pain, but after it he started to notice that his knee was bothering him. When I pried more into the verbal history, he did mention that yes, for years, a long time, he can get both knees hurting when he descends hills with hiking. But now, since this new onset 3 to 4 weeks ago, he notices the pain when he goes down steps in his home and when he does seated knee extensions for weight training. And the pain is typically on the anterior lateral compartment of the knee, but it can also kind of move centrally and move medially. So this already is starting to make me think about a strong diagnostic possibility. One, I don't think it's a structural lesion like a meniscal tear or a ligament tear or a fracture. And the reason I don't think it's something structural is because A, there wasn't a moment of memorable injury. Yes, it occurred after a day of playing soccer, but there wasn't that trauma. And most structural problems that are true structural problems and not just things that we see on images, most structural problems that are actually the root cause diagnosis, the patient, if not in nearly all cases, the patient remembers when it happened. There was a moment when the structure was compromised. So I'm not thinking there's a structural lesion. I'm also not thinking there's a structural lesion because the pain can move. For example, if he said it's just laterally, well then maybe there's a possibility that there was an LCL tear. But because it moves, we tend to rule out a structural compromise. Lesions in a ligament or lesions in a muscle or lesions in any bone, they're going to hurt where the lesion is. The pain is not going to move, and some days present laterally, and some days present centrally, and some days present medially. So because of this history, just by talking to him, especially with the years of bilateral knee pain, I'm really thinking this is low back. If we didn't have the bilateral history, meaning both left and right knee pain with descending hills, I would be more inclined to say it's probably, or it could be a knee derangement, a mechanical problem in the knee joint, or it could be a lumbar derangement, a mechanical problem in the low back. But because of that bilateral history, when I come out of the verbal history, I'm really thinking it's a low back joint derangement because I see this so often, especially in older individuals. They're commonly reporting pain with stairs, and I commonly see if we get their low back moving well again by moving into a specific direction to untweak the low back, then the knees at least feel better. I don't know if they necessarily move better. That one-to-one relationship is a little bit hard to ascertain, but their pain abolishes. So going into part 2 of my orthopedic evaluation, that's when I take orthopedic baselines. In orthopedics, in the clinical setting, that mainly is range of motion, strength testing, nerve tension, and a functional activity or a functional baseline, especially if the person can do it in the office. Sometimes the functional baseline is when I walk for 3 miles, it starts hurting at mile 2. That I cannot accomplish in the clinic, but most people have something that they can do in the clinic that's a functional movement or activity that reproduces their complaint, either reproduces their pain or an inability to do it, etc. So for part 2 of my orthopedic evaluation, full pain-free knee range of motion. So again, that makes me less likely to think there's a knee problem. If the patient has full extension with no pain, full compression into flexion with no pain, I'm not really thinking it's knee at this point. Secondly, full pain-free lumbar range of motion. And I put an asterisk because it does look full and he doesn't respond or doesn't report any pain or difficulties doing it. But because when I ask the low back to move, I'm asking many joints to move at one time, I know from my experience that if something's not moving 5% or 10% or maybe even 15 or 20% of the range of motion that it should have, I'm not necessarily going to be able to observe that at the get-go in the spine. For the extremity, I can definitely tell if something's 15% limited. 5%, maybe not as much. But in the spine, I know that it can look full and painless, but there can be something missing in terms of range of motion, something mechanically not moving to full range of motion that can be causing signs and symptoms. But when I wrote it down on my baselines, full and pain-free range of motion in the lumbar spine. That's why we test it. But that's the baseline. Baseline is not exactly how the person is all the time. It's how the person is at this very moment in the office. Thirdly, I wanted to get functional baselines like I mentioned. So stepping down from a step reproduced his pain. Very obvious, very clear, very consistent. Single leg squat, I asked him to do that. A double leg squat was fine. A single leg squat was painful. And then single leg hopping, no pain. That kind of doesn't make me think knee as well. For extremity joints and the lower extremities, for weight-bearing joints, usually, not always, usually a single leg hopping is a lot of force through the knee. So if the problem is in the knee, it's going to become symptomatic. Not always, but I try to see if we can get more than one functional activity baseline in the clinic if possible. Because again, the more consistent sound baselines we have, the more we have to test off of, the more we can really use the cause and effect algorithm and put it to use. So going secondly, strength. So hip flexion, I tested that, straight leg raise hip flexion, 5 out of 5, no pain bilaterally. Knee flexion, I tested the hamstrings in prone and in seated, 5 out of 5 through the range of motion, no pain. Knee extension, again, he mentioned that the long arc quad can reproduce his pain quite consistently. So for knee extension, I didn't just test at 90 degrees. As with the hamstrings, when I'm thinking there could be a tendon problem or a structural problem possibly, I want to test through that range of motion. So if the patient is seated, I have him resist my pressure, kicking all the way out into a straight leg, and then I have him pull back under the table against my pressure through the whole range. So the whole range, at least there, meaning from 90 degrees of knee flexion to 0 degrees of extension. And when I had him go through the whole range, we could reproduce that pain at about 40 degrees of knee flexion. So that can incriminate a tendon. If there's pain during motion with resistance, then it could be a tendon problem. But again, nothing in the past is making me think tendon because it moves around. But it's a good baseline to have. So I know that if we go through the range of motion, resisted knee extension, I'm pushing against him and he's extending his knee from 90 degrees of flexion to full extension. The other day, it reproduced the symptoms at about mid-range, 40 degrees of flexion or so. He could do it though, very strong. So pain during motion, which is often a mechanical problem. So I've talked about that before, pain during motion versus end range pain. Pain during motion is often a mechanical problem, even if it's under resistance, especially if it's not under resistance, right? If the tendon's not even being loaded and the person goes up and it's painful during and then it clears, then I'm really starting to think there's a mechanical problem, meaning a joint's not moving well and something in that range of motion is just, not feeling good and not working, either because the problem in this example is in the shoulder joint or in the neck or mid-back joints, remains to be seen. But pain during motion, especially without load, makes me think of a joint, and under load can be a joint, could also be a tendon or something else. But that's the orthopedic baselines. It only takes a few minutes to gather all these, but you want to make sure we have them. Oh, straight leg raise was also negative. Straight leg raise bilaterally was negative. He got to about 90 degrees, so great hamstring length and sciatic nerve excursion for that test. Now, part 3 is the testing. So because it only took a minute, I did structural testing. I did orthopedic special tests, the LCL, MCL, and ACL. They were all fine. I did them just because it literally took 30 seconds, not because I was really thinking there was a ligament problem, but an absence of a positive test there is strong for ruling out ligamentous injury. So there weren't other orthopedic special tests. I didn't bother doing any meniscal tests. But this is where, again, my orthopedic evaluation really differs from that of other clinicians, because other clinicians will rely on quick orthopedic special tests and or imaging. And I do not think this person needs an image at all. But my third part of my orthopedic evaluation, since that testing was inconclusive or at least negative for ligamentous injury, I start doing repeated movement testing, which is really different than what most clinicians do. People might call it the McKenzie method, but it's basically repeated movement testing. So because he had full pain-free knee range of motion, because I've seen the pattern before with especially bilateral knee pain with descending stairs, being from the lumbar spine, I started my repeated movement testing at the lumbar spine. Because of prevalence, I started with extension, and not because he was obstructed an extension to the naked eye or anything else that was really screaming out at me with his personal individual examination, but because of prevalence and patterns and knowing that we bend approximately 4,000 times per day and we tend to sit in flexion. My curiosity was, if we could just restore a little bit of extension, will it help? So we did a set of extensions in prone. I got him to hip sag very quickly because he's a young, healthy individual and he can tolerate that amount of force. I gave him overpressure on the second set. The step down got better. The long arc quad with resistance at mid-range got better. And then I just put him in sustained to see if that was even better, but also to see if there was something that I was missing in the lateral side of the lumbar spine. If you do a lot of extension, you can reveal that extension is not the right answer. So if I do a little bit more and something jumps out at me, then I can change course now. We usually need more than 30 sets or 2 minutes of extension to kind of get that answer, but I put him up into sustained extension nonetheless, and he said that the pain was almost gone with the step down. So I rechecked his baselines. The baselines were improving considerably. He could tell the difference. So what we're going to continue to do at home is continue the repeated movement testing. Repeated movement testing means repeated. I need to know for this gentleman, 24, 48 hours, what happens if you do the extensions sustained or with overpressure at least 6 times per day. You look at your posture, you pay attention, you make sure you're not going into a lot of flexion to counteract what the extension is trying to do for the lumbar spine. Then you can try the long arc quad on the machine. You could obviously tell if going downstairs in your house every day is any better. So the repeated movement testing is continued because the test is not finished until we have a conclusive answer that more and more repetition of it is better. So instead of me sending this person to an office to get an x-ray or an office to get an MRI, or us just fiddling around with strengthening or stabilizing or any number of things that are common in physical therapy clinics all over the country, I continue my testing because I think that thorough testing gets the diagnosis right much more often. And let's just give a scenario that he comes back better. Well, then I'll just see if more extension will fix it all the way or I need to change something. But oftentimes for patients like this, I'm expecting to see them typically 3 or fewer visits because it is to me, it's quite straightforward. The low back can get a little stiff into extension, maybe not observable with the naked eye at the baselines, but gaining more extension, a little bit more fluidity with repeating that motion. I see this pattern a lot, so I would expect this person to be better, but I could be wrong. 30 extensions in the clinic could do a nice job at helping with the baselines, but maybe 300 over 2 days, the person comes back and says, the more and more extension I did, the worse it got, or it had no effect. And that's where I have to reassess. The testing is complete when the person can conclusively say better, worse, or no effect, and then we see what we need to change. So this is my orthopedic examination for a relatively simple knee pain patient. I will know more when I see this person again, but my prediction is that this gentleman just needs a bit more extension into his life, possibly some postural habits with the couch at home or the office, or the chair at his place of work or the car seat, something to get him a little bit more balance into his lumbar spine. That's my prediction, but we'll see at visit number 2.